Patients who have had total knee replacements will usually have two major goals in physical therapy: to regain motion and regain strength. Ideally, by the end of their time in outpatient physical therapy, a patient should be able to extend the operated knee to 0 degrees and flex it to 120 degrees. Their strength for flexion and extension should be equal to or greater than the strength of the non-operative knee. Your patients are likely to see one of your colleagues at some point in time or another on a day that you are off. To ensure intrarater reliability, it is very important that we are all measuring range of motion and strength the same way. We recommend that you wait at least 2 weeks after surgery to measure either range of motion or strength, since the presence of staples or stitches can cause discomfort to the patient and interfere with the ability to perform testing. It also gives an opportunity for swelling and pain to go down. After this initial measurement, we recommend that you measure once a week up until discharge. Here at Corewell Health, the standard way to measure passive range of motion is in supine, with overpressure from the therapist. The standard way to measure active range of motion, however, is in a seated position, with the patient moving against gravity under their own strength. To measure passive range of motion for knee extension, place a towel roll under your patient's ankle. Have the patient relax completely. They should not be contributing actively to the motion at all. The center of the goniometer should be aligned with the lateral epicondyle. The proximal end should be aligned with the greater trochanter. Align the moving arm along the midline of the lower leg towards the lateral malleolus. Apply gentle overpressure to straighten the knee as much as possible. When you get to a firm end feel, record the number. To measure passive range of motion for knee flexion, have the patient relax completely. Apply gentle overpressure to bend the knee as much as possible. Like before, the center of the goniometer should be aligned with the lateral epicondyle. The proximal end should be aligned with the greater trochanter, while the moving arm aligns with the lateral malleolus. When you get to a firm end feel, record the number. To measure active range of motion for knee extension, have the patient sit at the edge of the mat table. Raise it just enough so that the foot is off the floor, or have the patient's shoe off so the foot is able to slide. You may need to add a towel roll under the knee for correct alignment. Have them actively straighten the knee as much as they can against gravity. This takes into account the strength of the quads and the length of the hamstrings. Align the goniometer along the same bony landmarks as before. When the patient is unable to straighten their knee any farther, record this number. To measure active range of motion for knee flexion, have the patient sit at the edge of the mat table. Like before, the foot will be off the floor, or the patient's shoe will be off, allowing the foot to slide. Have them actively bend the knee as much as they can against gravity. This takes into account the strength of the hamstrings and the length of the quads. Align the goniometer with the same bony landmarks as before. When the patient is unable to bend their knee any farther, record this number. A major change in practice this year is that we are recommending that you measure strength for knee flexion and extension with a handheld dynamometer rather than using manual muscle testing. We are also recommending the use of 2 stabilization belts. The first belt gives the patient something immovable to push against, while the second belt prevents the patient from compensating by adding force from the hip. To measure knee extension strength, the patient should be sitting at the end of the mat table. The knees and hips should both be bent to 90 degrees. You may need to add a towel roll under the knee for correct alignment. Use one stabilization belt to secure the thighs to the mat table to prevent hip flexion. Use the other to loop around the ankle and stabilize on the vertical metal strut under the mat table. Take up enough slack to keep the knee bent to 90 degrees. The lower stabilization belt should be parallel to the femur and the floor, but perpendicular to the tibia. Place the handheld dynamometer between the stabilization belt and in front of the patient's ankle. If the patient reports discomfort to the skin as they press, you can add extra padding with a folded washcloth. Have the patient push with all their strength. Use your voice to motivate the patient, using strong verbal cues, such as push, 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 or go, 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 go. Give the patient 3 tries. Record the best of the 3 numbers. To measure knee flexion strength, the patient should be laying in prone. The knee should start bent to 90 degrees. Use one stabilization belt to secure the hips to the mat table. The other stabilization belt should go around the patient's ankle and then around your trunk. Take up enough slack with the stabilization belt to make sure that the patient's knee is still bent to 90 degrees. The belt should be perpendicular to the tibia and parallel to the femur and the floor. Brace your own thighs against the mat table to prevent extra movement. Place the handheld dynamometer between the back of the patient's ankle and the stabilization belt. Use your hands for further stabilization. If the patient reports discomfort to the skin as they pull, you can add extra padding with a folded washcloth. Have the patient pull with all their strength. Use your voice to motivate the patient, giving strong verbal cues such as pull, 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 or go, 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 go. Give the patient 3 tries. Record the best of the 3 numbers.